Thank you, Dr. Namrata. Am I audible?
Yes.
Yeah. So when we talk about keratoconus, this is how we like to treat the keratoconus, where based on the location of the cone, whether the cone is centered or whether the cone is decentered. And as the previous speaker said, that if there's a progression in keratoconus, we would like to stop the progression. Ultimately, whatever we do, the ultimate goal is visual rehabilitation. Interestingly, the treatment of keratoconus includes certain things which makes doctor happy, which is stabilization of the cone. As a doctor, we would be really happy that, wow, we have stabilized your cone. But as a patient, the other person may not be happy until the visual rehabilitation occurs. So the visual rehabilitation is done using different modalities, and few of them we actually already discussed. So my job is relatively simple, where I just have to tell where exactly we can use these things. Things like contact lens, a PRK, topo-guided PRK, or intracorneal ring, and phakic IOL are the majority of them which we will be talking about. So when we talk about the visual rehabilitation in contact lens, the simplest treatment is contact lens. Now, contact lens, where does contact lens fit into the entire thing? Well, it fits when the cone is very advanced and when the cornea is irregular. And if we are able to do a cross linking in this cornea, we surely should go ahead and do cross linking and then use the contact lens. Now, if the contact lens, if the cornea is not thick enough to do the contact to do the cross linking, we can still use contact lens till we go for the definitive treatment, like how Dr. Namrata said, corneal transplantation. So where contact lens fits in, well, most of the time, in most of these cases, we can actually fit the contact lens. Let's take my talk would be based on cases, so it's more easy to connect with the subject. Now, let's take this young lady who had come for cross-linking. And on examination, initially, we saw the corneal thickness was 384 micron, which is low, but still not impossible to do cross-linking. However, when we did an NTA segment OCT, we found out the corneal thickness was not, the true corneal thickness was much lesser. And in fact, the corneal stromal thickness was even less. It was like 206 micron, which may not be the best case to do collagen cross-linking. Such kind of case, we can do visual rehabilitation using scleral, mini scleral, or any advanced contact lenses. The advantage is here, it's non-surgical advantage. Well, it can visually rehabilitate patient very fast. And if it progresses later on, we surely can do a corneal transplant procedure. So all these things we would evaluate based on effectiveness of the treatment here, which is very effective, and nothing can give better vision than that. Technically, well, it may require somebody who is trained in such kind of contact lens trial. Though it's not very difficult. Usage wise, well, it can be used for multiple corneal condition, hence very useful technique. And is it value for money? Of course, it is value for money. So what do we learn from here? Well, newer contact lens can be fitted in advanced cases of keratoconus also. The best visual rehabilitation can occur with a good fitting hard contact lens. And very advanced cones, be aware that you may end up miscalculating corneal thickness based on only certain diagnostic procedures like Pentacam, and hence you might want to use anti-segment OCT there. Coming to the next thing, intracorneal ring implants, which Dr. Rajesh Sinha already elaborated upon. Hence, I don't need to tell you anything in detail, but where does it fit into our scheme? Well, where the cone is centered, or it's decentered also, where we can use asymmetric ring, but the cone is centered and with low spherical equivalent. That means the power is relatively low. And there we surely can use intracorneal ring implant following the cross-linking by stabilizing the cornea. The treatment is very simple, but where is the role of Intex? If you can see on the right side, a cone which is pretty significant, by using a ring becomes much more localized in the center, and progressively it becomes much more regular surface. And such kind of thing can give very good vision even with the glasses, or in worst case with contact lens. Sometimes the outcomes are so good that very advanced cone, we can make it relatively okay and can give you good vision with either contact lens or even glasses. Sometimes the vision improvement may need a contact lens on top of it. Where it works best is cases of post-LASIK ectasia. One such case, 30-year-old female who had LASIK history and had post-LASIK ectasia, underwent intracorneal ring implant along with the collagen cross-linking. And as you can see here, from quite significant ectasia, the surface became much regular, and at the end, patient had very good vision outcome, as well as the surface was as if there was the regular LASIK done. So a single ring, as Professor Sinha was showing earlier, can actually give quite significant vision outcome and quite rapid visual recovery in such kind of cases. So how does it fit into our scheme? Well, effectiveness of treatment wise, moderate to mild keratoconus, it works wonderfully well, especially with the low spherical equivalent. However, the outcome may not be very predictable. So we cannot predict that you don't need to use glasses or contact lens. We cannot offer such kind of outcome. Technically, it's very simple procedure, but sometimes planning requires an experience, and the person needs to be a little more experienced about that. There's no other usage for this procedure other than keratoconus and post-LASIK ectasia. Hence, it would be limited to such kind of condition. Value for money, well, the cost can be sometime inhibitory factor for a certain patient, but if we have a femtosecond laser, this is certainly a procedure which can be considered. So what do we learn from here? Where intracorneal ring implants or intacs can improve quality of vision in especially mild to moderate keratoconus. Especially if they have low spherical equivalent or low power, it can give very good vision outcome also. It's really best treatment for post-LASIK ectasia. And if you already have a femtosecond laser access, this is certainly a treatment which you can consider in your armamentarium. The next treatment modality is phakic intraocular lens. Now, where does it fit? A cone which is relatively centered, which is stabilized using cross-linking, and for the visual rehabilitation, we can consider. It's very simple treatment, easily reversible, and gives you very good quality of vision. And it's extremely useful in cases of keratoconus with myopia or keratoconus with relatively high power. First, it has to be cross-linked these corneas. And after waiting for probably 6 to 12 months time, but the cornea is stable, we surely can think of a toric phakic intraocular lenses. There are quite a few of them in market, and we are spoiled with the choice in our country. Let's take an example. A young male who had keratoconus, who had undergone cross-linking and intracorneal ring implants 2 years ago, had relatively stable ocular surface. And if you can see, the cone also was looking quite nice and central, and had a significantly high spherical and cylindrical power. Such kind of case can be quite decent case for a phakic IOL. And as you can see from here, the surgery is done under topical anesthesia. 2 side ports are made and under either viscoelastic or under irrigation with the saline. We can insert a phakic intraocular lens inside the eye. When we combine following intracorneal rings or intacs, sometimes the visibility may be a little bit affected, but we can turn the eyeball in different direction, and which can still give you a decent visibility. Of course, the treatment is simpler, where we just have to tuck the lens behind the iris and remove the viscoelastic, and the surgery is over. Overall surgical treatment is very simple, and vision outcome is really nice. If you can see from here, from pre-op, significant amount of glass power to relatively quite low refractive error, and a quite significant improvement in overall quality of vision, this patient was really happy. So does it mean that everybody we can use such kind of lenses, even though the case here looks very central cone? And I was quite happy to offer this procedure to my patient. But when we evaluate this case further, we realize that the topographic axis, what we can see from here, which is very intuitive and very normal, which looks like 70-degree there, was not correlating, was not matching with the refraction axis, which was far away from there, which was 20-degree. So when there is a mismatch between the objective assessment of keratoconus and the subjective assessment, this may not be the best treatment to offer to the patient. Also, beware that falsely deep central anterior chamber in keratoconus can fool you. As you can see from here, more than 3 millimeter anterior chamber depth in such cases, which is required in keratoconus cases, sometimes can falsely be present due to just ectasia in the center. And in such cases, we may end up in crowding of the chamber and maybe ultimately a glaucoma. So where does it fit into our scheme? Effectiveness wise, well, it's best reserved for regular and central cone. So it cannot be done for every cases. Sizing can be an issue. So the surgeon needs to be aware of how to handle these things. Technically, it's very simple procedure and can be performed by any cataract surgeon also. And other usage wise, well, it can be used for myopia, hyperopia, and many other things. Hence, phakic IOL is certainly a procedure which can be used by many surgeons. Value for money, well, it certainly does not require any special infrastructure or instrument. Hence, it's certainly value for money. So what do we learn from here? Well, the phakic IOL are best reserved for central cone, especially with the high spherical equivalent. It works wonderfully well. However, beware where topo and refraction do not match, or central anterior chamber depth may be sometimes misleading. We can also use toric IOL in advanced cones or central cones, which are relatively stable or which are later age group, as Dr. Tityal was showing that later age group, it does not progress much. So one such case we are talking about a relatively young male who had very high myopia and with keratoconus and required a corneal, required a cataract surgery, underwent a cataract surgery with a customized toric lens with 4.5 diopter cylinder and minus 12.5 diopter spherical power. Post-operatively, patient had excellent vision outcome and patient was very happy. So in certain cases, where can we use these toric lenses? Where there is correlation between manifest axis and topographic axis, or where the cone is relatively asymmetric, but using the intracorneal ring implants, if we have made it relatively regular, in such kind of cases, we can think of using it. So where do we fit in our system? Well, effectiveness of the treatment, it's best reserved in certain cases. Not every case of keratoconus, we should use toric IOL. Technically, it is relatively simple treatment and any cataract surgeon can use it, but requires little more experience, especially in complex toric IOL calculation. It can be used, the toric IOL can be used for any regular cataract surgery, so it's certainly useful technique. Value for money wise, well, it does not require any special infrastructure and hence certainly value for money. So what do we learn from here? Toric IOL are best reserved for central cone, especially when topo and refraction are not matching, not use that, and selected cases would be the best use for that. Topo-guided partial PRK. Coming to the cornea, which are relatively irregular, we can regularize the cornea by treating with topolizer and loading it to our certain laser platforms, which can regularize the surface and can make the cornea much better. So if the cones which are relatively central, we can reduce the cylindrical power there and can improve the quality of vision and quantity of vision after the cross-linking. And when the cone are decentered, we can make the cornea more regular and can possibly visually rehabilitate them using a simple treatment like glasses, contact lens. So preoperatively, a cornea like this, which are relatively irregular, by treating with the laser post-operatively, we can make it quite regular and which can be visually rehabilitated using either glasses or even the soft contact lens also. So overall, quite exhilarating outcome by improving the irregularity on the cornea. And it can certainly be useful in selected cases where especially corneal thickness is good. Technically, it requires a little more experience in planning, but it's a very simple treatment. The same platform can be used for other refractive surgery. And if the LASIK machine is there, which is compatible for such kind of topographic treatment, certainly a good treatment. So what do we learn from here? Well, the good pachymetry cases where somebody with a good corneal thickness, where we are able to get repeated and reliable topolizer or aberrometry readings, with maximum ablation around 50 to 60 micron, more of the cylindrical power than spherical power, we can regularize the cone, and it can be certainly a very good treatment. If the cornea is irregular or a very advanced cone where the contact lens are not fitting, previous speaker spoke about the corneal transplantation. And we surely can do a corneal transplantation, especially the deep anterior lamellar keratoplasty, where we do not change the inner layer of the cornea and just change the stromal layer of the cornea. And these kind of cases would eliminate the chances of rejection, still giving a very good visual outcome and giving a long-term benefit for the vision to the patient. The corneal transplant in such kind of cases can be done using different techniques. The one which I'm showing here is using the femtosecond laser and making a mushroom shape cut, but it certainly can be done using any vacuum trephine or normal trephine also. The overall treatment procedure is not very complex, but does have little learning curve, and which possibly with the with the multiple platform and teaching webinars available is not very difficult for everybody. Overall, where does it fit into our protocol? Well, effectiveness of the treatment is very good, but it certainly requires some kind of technical expertise. With the complexity of the procedure, you do need some training. Also, somebody who wants to perform should have an organ transplant act certificate or HOTA certificate. It can be useful for many other corneal diseases. So if you get an expertise in this thing, it certainly is very useful. Does not require any special instrumentation. So it's certainly a value for money. So what do we learn from here? Well, it's best reserved for very advanced cone and still has a little learning curve. And it's for trained cornea surgeon and requires long-term follow-up. So finally, to summarize, the keratoconus is treated based on laterality or the central, rather centration of the cone, whether it's centered cone or decentered cone. Once we stabilize the cone, and then the visual rehabilitation can be achieved using different techniques, and case selection is absolutely mandatory. Thank you very much.